Hello and welcome. Today we're diving into a rare and complex neurological disorder called neuroacanthocytosis. This condition, often misunderstood, affects the nervous system and red blood cells in unique ways. Join us as we explore its causes, symptoms, diagnosis, and current management strategies. Neuroacanthocytosis isn't caused by a single factor, but rather by a group of genetic mutations. These mutations disrupt the normal function of proteins essential for maintaining the shape of red blood cells and the healthy operation of the nervous system. The most common genetic culprit is a mutation in the VPS3A gene, responsible for producing choline, a protein with an unclear but vital role. Other, rarer, genetic mutations can also lead to this condition, highlighting the complex genetic landscape of neuroacanthocytosis. The core of neuroacanthocytosis lies in its impact on red blood cells and neurons. The genetic mutations lead to the abnormal formation of red blood cells, giving them a spiky appearance under a microscope. These distorted cells, called acanthocytes, are less flexible and more prone to damage. Simultaneously, the nervous system, particularly the basal ganglia, undergoes progressive degeneration. This neuronal loss and dysfunction result in the characteristic movement disorders and cognitive changes seen in the disease. The precise mechanisms linking the genetic defects to neuronal damage are still under intense investigation. Neuroacanthocytosis is exceedingly rare. Precise prevalence rates are difficult to determine, but it's estimated to affect only a handful of individuals per million. Due to its genetic nature, it can occur in any population, though certain mutations might be more prevalent in specific geographic regions or ethnic groups. Often, the lack of awareness and diagnostic challenges can lead to underdiagnosis, further obscuring the true prevalence. The signs and symptoms of neuroacanthocytosis are varied and progressive. Neurological manifestations are prominent and often debilitating. These can include chorea, involuntary, jerky movements, dystonia, sustained muscle contractions causing twisting and repetitive movements or abnormal postures, Parkinsonism, characterized by slowness of movement, rigidity, and tremor and seizures. Cognitive decline, psychiatric symptoms like depression or obsessive, compulsive behaviors, and peripheral neuropathy are also frequently observed. The acanthocytosis itself rarely causes direct symptoms, but is an important diagnostic marker. The severity and combination of symptoms vary considerably among individuals, making diagnosis challenging. Diagnosing neuroacanthocytosis requires a multifaceted approach. A thorough neurological examination is paramount to assess the characteristic motor and cognitive impairments. A blood smear is essential to identify the presence of acanthocytes, although it's important to note that acanthocytes can be found in other conditions. Genetic testing plays a crucial role in confirming the diagnosis by identifying the specific gene mutation responsible. Brain imaging, such as MRI, can reveal structural changes and atrophy in the basal ganglia. Other tests, like nerve conduction studies, may be used to evaluate peripheral nerve function. Because of the overlapping symptoms with other neurological disorders, neuroacanthocytosis often requires a differential diagnosis process to exclude other more common conditions. While there are not necessarily formally classified types, it's helpful to think of neuroacanthocytosis as a spectrum of disorders based on the specific gene involved and the predominant features. For example, Chori acanthocytosis is often associated with VPS1/3A mutations, while Macleod syndrome, another form of neuroacanthocytosis, is linked to mutations in the XK gene. Understanding the specific genetic and clinical presentation is crucial for tailored management. Currently, there is no cure for neuroacanthocytosis, and treatment focuses on managing symptoms and improving quality of life. Medications can be used to alleviate movement disorders such as chorea and dystonia. Botulinum toxin injections may provide relief for focal dystonia. Anti-seizure medications are used to control seizures. Physical therapy, occupational therapy, and speech therapy can help maintain mobility, independence, and communication skills. Nutritional support is often needed to address swallowing difficulties and maintain adequate nutrition. Psychiatric symptoms are managed with appropriate medications and therapies. Supportive care, including psychological support for patients and their families, is essential in navigating the challenges of this progressive condition. Since neuroacanthocytosis is a genetic disorder, primary prevention, in the traditional sense, isn't possible. However, genetic counseling is vital for families with a history of the condition. Carrier testing can identify individuals who carry the mutated gene but don't exhibit symptoms, allowing them to make informed decisions about family planning. Prenatal testing is also available for families at risk. The prognosis for individuals with neuroacanthocytosis is generally poor. The disease is progressive, and neurological symptoms worsen over time. The rate of progression varies significantly among individuals. Complications such as pneumonia, falls, and malnutrition can contribute to reduced life expectancy. However, recent research is offering glimmers of hope. Studies are underway to investigate potential gene therapies and other targeted treatments aimed at slowing or halting disease progression. Understanding the role of choline and other affected proteins is a key area of focus, with the goal of developing therapies that can restore their normal function. While a cure remains elusive, ongoing research provides hope for improved treatments and a better quality of life for individuals affected by neuroacanthocytosis.